So you called me. I found a missed call. It's not there. Okay, told me anyway.
Good morning. Well, good morning. I'm going to have to go back to Fort Smith once before I go there, but I really liked Fort Smith when I was a little boy.
Well, it's changed a little bit.
Oh, it's changed a lot, I'm sure.
It's strange to think how much it's changed in the 15 years I've been down here. The thing's different.
I'm disappointed, and every time I tell you this story, you have to remind me the name of it. I'm disappointed that I'm going to stop talking.
You don't think I can multitask? It's because I can't multitask. I get full credit, isn't that wonderful? What I haven't figured out is, what does it count for? I don't get a bonus at the end of the week.
I imagine you get far more of these credits than you need.
I do. I haven't needed a credit in years.
Well, I was awfully disappointed when they paved over that big, wide street down Fort Smith, because I was intrigued with a street made of bricks, and I was also intrigued because there was no street in Little Rock anywhere near as wide as the street was. And
Garrison Avenue.
yeah, I need to remember that, Garrison Avenue. And my relatives up there said that that was built because they had big parades from Fort Chaffee that would go downtown. At least that was the explanation they gave for that street being so big, so wide.
Well, I don't really know that answer, but it was between the Catholic Church and the bridge across the river. And it is a wide Garrison Avenue. So on one side you had the garrison, the fort. On the other side you had the city, and then it sort of grew. But it was brick. It was bricked right at 100 years ago, and it had trolley cars going right down the middle.
Now, I don't remember that. Of course, we had trolleys here for years back. When I was a little boy, for a while we lived on Kavanaugh. In the morning, before school, there would be a trolley go by our house every 6 minutes, taking children to school.
Well, it was the system, and it worked.
Yes.
But there are still the trolley car poles on Garrison Avenue because they are set up for a lateral strain on them. They're steel poles, sort of an I-beam with diagonal lattice work in them, and that supported the trolley car electrical system. Mm-hmm. So when they recharged a little part of that, all they had to do was put the wires up. The poles were in place. But they've got a little trolley system downtown now. Now. It runs on holidays, weekends, that sort of
Brandy, maybe that's slowing people down.
Kind of like this.
Yeah, very soon. One of the ophthalmologists there was, he retired, didn't have anything to do, so he brought back the trolley car.
Well, that reminds me, there was a student There were two brothers named Bone that were very good, and one went into ophthalmology in Fort Smith. You remember my Bone?
I remember the name, but I can't put a face on it. Moulton was that ophthalmologist, and there's been a bunch of them, and they're quite good.
His brother went up the academic ladder and became a dean somewhere, but he's died since then.
Do deans die?
Yeah.
I thought they went on forever.
No.
Me? With you.
I'll tell you, if we got time, I'll tell you stories after stories. He was a phenomenally good man. He had coronary artery disease. He lived outside here. One summer in July, the temperature was 100 and something. I drove by his house. He was out in the front yard with pick and shovel, digging trenches, putting in a sprinkler system, and I knew he had coronary artery disease. So next time I ran into him, I said, "Dr. Sorry, I don't think the cardiologist will think what you do out there in 110 degrees digging trenches." He said, "I did that all morning, had no answer." We were sitting in his office. The minute I walked through that door into the dean's office, I started having answers.
Yeah.
Now that, the psychological stress doesn't surprise me.
Like you have all orders.
Oh.
In that there is inpatient. It's that.
I've got a long list of jobs I don't want.
Well, Dean is top of my list.
It has very high turnover rate. What are the troops today?
Well, it's up to you. Anytime you're ready.
Oh, I don't have a CME code is
It's 325001. Hoping that's correct.
Okay. So basically, it's an important topic for me, but I don't think, whether how others would feel it. So this is about, I'm starting with a case. It's a 45-year-old lady who had hypertension, migraines. She also had uterine cancer, for which she had undergone hysterectomy, and smoking. She had sudden onset of headache, and it was frontal in location, following which she noticed numbness and weakness of her right upper extremity. She also had some slurred speech and some facial droop, and so for this she was presented to the outside hospital. She has been non-compliant with her medications for the last 2 weeks. Very typical story what we find on day-to-day basis, right? So like over there at the outside hospital, her blood pressure was in the 180s by 80s, and then they treated her with antihypertensives and transferred her here. So upon arrival over here, her blood pressure was around 134/65, her pulse rate was 70, her respirations were 18. She was awake, she was alert and oriented. She had some mild degree of expressive aphasia. She could name simple objects, but there was decreased fluency. There was a right facial droop, and her right upper extremity was completely plegic. The rest of the extremities, the power was 5/5. The sensory system was intact. She did not have any neglect. And on her laboratory workup, her drug screen was negative. All her laboratory parameters, CBCs, BMP, coagulation profile, everything was normal. Okay. So it's not unusual that we get a non-contrast CT. We have a left frontal hemorrhage, which is heterogeneous. It was 14 cc's. And she was stable, and we had then continued aggressive blood pressure management, and hypertonic saline was started prophylactically. Okay. About 6 hours later, we noticed that she complained of worsening headache, and where even her arm became plegic. So repeat imaging was performed. That showed expansion of the left frontal hemorrhage. As you see, it is more heterogeneous than what it was before. And I think too many gases over here. So it is more heterogeneous than what it was. So there was expansion of the left frontal hemorrhage. CTA did not show any underlying vascular lesion, and there was no spot sign. And because she had a history of uterine cancer, we got an MRI of the brain to make sure there was no underlying malignancy because she was young. So it was negative. And the MRV, because it was lobar, was performed in location, so the MRV was normal. CT chest abdomen pelvis did not show underlying malignancy, but there was a right adrenal lesion. So, we then I did, sent her then a plasma metanephrines, normetanephrines, and then aldosterone were sent. These were normal. And in spite of all the hyperosmolar therapy as well as controlling her blood pressure, she still continued to expand. The hemorrhage started getting worse. So which prompted us, a young person, it was just, of course, hypertensive in origin, but then she's continued to expand her hemorrhage. What are the other secondary causes? So we underwent a diagnostic and an angiogram, and we noticed there was a string of bead appearance. As you see, so the extracranial ICH, so there is some beading of over here, the ICH, as well as even in the vertebral arteries, and the superior pole of the, the left kidney. So which prompted us to make a diagnosis of fibromuscular dysplasia. She also had an incidental left ophthalmic artery aneurysm, which was unruptured, so that was incidental. So now we have a diagnosis of FMD, so this is because of the string of bead pattern. And 4 months later, so she was discharged to the rehab. 4 months later, she underwent pipeline stenting for the aneurysm because it was unruptured and it needs to be secure. Okay, so she got then a discharge, and then she was fine. She underwent the procedure, the aneurysm got oiled, then she was stable. But 9 days after it, again she rebled into the same location. But now she also had some amount of IVH component to it. So she was then ebulic, she was drowsy, and her right side was completely plegic. She also lost sensation on the right side, and she again required, admissions to the unit. And then, after a few days, then her condition improved, and she got discharged to rehab. And now the right side is a bit weak, but she's able to ambulate and she's able to move her right hand. So now you see it was then a typical hypertensive hemorrhage, but then you have a whole different picture adding to the to her initial hemorrhage. So this was today in my brief talk. I'm going to discuss mainly about then a brief overview of intraventricular hemorrhage because it's a least well discussed topic. Various imaging modalities and predictors of hematoma expansion. Our patient had significant expansion of hematoma and the outcome in these patients. So we all know, intracerebral hemorrhage, it accounts for about 15% of the strokes. The annual incidence is about 10 to 30 per 100,000. We know that the mortality, 30-day mortality, is significantly high. It's about 30 to 50%. And most, we divide classically, intracerebral hemorrhage has been divided into primary as well as secondary. Primary if it is because of hypertension or because of amyloid. Secondary if there's underlying structural lesion like AV malformation, coagulation, then coagulopathy or tumors. Okay. So this is the brief overview. So intraventricular hemorrhage. So it, as the term defines, it is just blood within the ventricular system of the brain. Okay. So why it is important to us? It can happen in about 30 to 50% of the time with intracerebral hemorrhage. And in case of subarachnoid hemorrhage, you see it in 25% of the time. Why is it important? Because the mortality goes up to 50 to 80%. So if you have an IVH. So that's why, knowing it is very important. So there are two different classifications to intraventricular hemorrhage. It can be primary or it can be secondary. Primary means if it originates within the ventricle. So the choroid plexus could be the source of it. The underlying parenchyma is not involved. Secondary means if it's coming from the parenchyma and going within the ventricle. So those are, secondary form of hemorrhages. Okay. So then primary IVH, it's not a new term, and it was initially then it had discovered in 1881. So it is blood within the ventricular system without associated laceration of the ventricle parietes was the initial definition. It's very rare, seen in about 3% of all the intracerebral hemorrhages. Different etiologies to it. Hypertension is the most common cause. The other causes could be either a vascular malformation, dural AV fistulas, arterial dissections, aneurysm, fibromuscular dysplasia, moya-moya disease, coagulopathy, and tumors of the choroid plexus. So these are the common cause of primary IVH. When you have a patient with moya-moya disease, usually they have intracerebral hemorrhage, but in 80% of the time we also have IVH. So IVH is really so common in moya-moya disease. And once in moya-moya disease, if you have an IVH, they'll have a recurrent IVH, and a recurrent stroke is very high when compared to a primary intracerebral hemorrhage causing, because of hypertension. So it's very important to know the etiologies of this. Now this was the original, then a description by little. So there are 3 different presentations. Either these patients could be, comatose and then they die within 48 hours, or you can have focal the neurological deficits, or you can have sudden headache, drowsiness, and confusion without any focal signs. So 3 different manifestations. Why it is important to differentiate primary from secondary? Because primary has a much better prognosis. The mortality is way much more lower. It's about 20 to 40% in case of primary. As we said, secondary is like 50 to 80%, right? So the different symptoms that it can be presented with was, you can have headache, you can have focal symptoms, you will have elevated blood pressure, you will have elevated temperature. Classically, you will have fever because the hypothalamus is getting irritated. You will have neck stiffness, cardiac arrhythmias, and different presentations. You will have altered mental status, cranial neuropathy, focal deficits can also occur. So different patterns are seen. Now, like this was an initial trial which correlated the volume of IVH in ICH. So like out of, then initially they had included 129 patients, and 47 patients of them had intraventricular hemorrhage. So like the top curve, it's just those with a GCS less than 8. So the first one is GCS less than 8. IVH volume was more than 80 cc's. The next one was GCS less than 8, but then the ICH volume was 20. Okay, so this one was GCS more than 8. The ICH volume was more than 80. This is again GCS more than 8, but the intracerebral hemorrhage volume was 20 cc's. So as you see, this is the IVH size, and this is the mortality. As the IVH size goes up more, bigger, and then the mortality becomes bigger. So this was the initial trial, which showed that patients with ICH also had a larger intracerebral hemorrhage volume, as well as they also had a lower GCS. So this is as your GCS is going up and your volumes are going up, your ICH volume is also going up. Okay? So the 30-day mortality of patients with IVH was about 43% when compared to those who did not have hemorrhages, only about 10%. So significant difference with IVH, presence of IVH. And the IVH volume and GCS were predictors of 30-day mortality in this study group. Now, what was the significance of IVH in supratentorial ICH? So they had evaluated 48 patients. They located the hemorrhages were present at different locations. It was most commonly found in putamen, followed by thalamus, lobar, caudate, and then miscellaneous locations. So this was the distributions that they evaluated. So what they determined was patients with larger ICH. We know that larger ICH means you'll have a parenchymal as well as a ventricular portion. They did poorly. So as you see, this is the total volume, both parenchymal as well as ventricular volume, and this is the outcome. More the volume, poorer the outcome. And then this was assessing only the ventricular volume. So that is how much of the blood is there within the ventricles and the outcome. What they determined was the lethal volume. If your ventricular blood is more than 20 cc's, they are the ones who are going to die. So this paper denoted, hey, the ventricular volume correlated with the mortality. And the same goes with the parenchymal volume. We all know that if the volume goes up, the outcome also then is worse. So this is just simple to it. So the lethal volume was determined. If you have your location within the putamen, so the outcomes correlated with both the total volume as well as the blood within the parenchyma, but not much with the ventricular volume. Whereas if it was in the thalamic in location, so it correlated with the amount of blood within the ventricle, the total blood, as well as, but less correlationship with the parenchymal portion. Makes sense, right? I mean, thalamus is near the ventricle, so ventricular blood will influence its effect more. Now, what about the different anatomical correlationship? This was a bigger trial, which included about 406 patients. 45% of the patients had intraventricular hemorrhage. 100% of patients with caudate hemorrhage had IVH, whereas in thalamic, it was present in 70%. If they had larger parenchymal blood volume, like lenticulum or lobar, if it was larger, then you had IVH. Now, why then ICH location was a predictor of IVH, as we say. if it was caudate hemorrhage, you see it in 100% of the cases will have IVH. Okay. So why it is important to know, again, the patients with IVH, they had twice the likelihood of poor outcome at discharge, even after controlling for other risk factors. And patients with IVH also were 3 times more likely to die when compared to patients without IVH. So that's why the presence or absence of IVH more important. The outcome is worse and the chance of death is higher. One exception to it was caudate. All the patients with caudate, they did well, so because, that's just because of the location, it is close nearby. This paper also determined what is called the decompression range. That means so a particular volume in this area, below which you will not have any IVH and above which you will have IVH. So if you have in the thalamus, the decompression range was around 7 to 12. So below 7, you will never have IVH, and above 12, you will always have IVH. So this was interesting that if you're going to have this much amount of blood, you're definitely, the likelihood of IVH is going to be high. So what was the impact of IVH and hydrocephalus on the STICH trial? We all know the STICH trial. The outcomes of the surgery was not superior compared to medical management. Only this was in the STICH 1 trial. And so what they compared is patients without IVH was 30% had favorable outcome when compared to that of IVH. So again, patients with IVH did poorly. What happens if hydrocephalus was added to IVH? Again, it worsens the outcome from 15, it went down to 11. Okay? So we knew that the STICH trial was entirely negative. So patients with IVH and without IVH, there was no difference with surgical outcome. Okay? So this interpretation can be done on a larger group. It was around 600 patients, presence of IVH and hydrocephalus, independent predictors of poor outcome. So these are the different scoring systems which then have been used in the intraventricular hemorrhage. The first is the IVH score, and then so the IVH score, so they noticed the blood present in each ventricle. So the lateral ventricle, whether there was no blood, sorry, the slide is not very clear, but different sources, all the sources were not great. So they gave a score of 1, if it was less than 1/3, 2 if it was between 1/3 and 2/3 more of blood, 3 if it was more than 2/3 full, and hydrocephalus if it was present or absent, third ventricle and fourth ventricle if blood was present or absent. Okay? And then for each lateral ventricle, so this is the next score which has been used in literature, the Greb score. You have got the modified Greb score also, but they all are pretty good, So the Greb score, initially that is grade 0 if there's trace blood, grade 1 if there's trace blood, 2 if it was less than 50%, 3 is if it was more than 50%, 4 is if it was completely full and it was expanded. Third and fourth ventricle was if there was no blood, and then if there was blood present, or if it was filled with blood and expanded. And then you got this last one, that is the Leroux score, 0 to 16. So again, 0 was if there's no blood, 1 if there was then a trace amount of blood, 2 if it was less than 50%, 3 is if there was more than 50%, 4 if it was completely full and it was expanded. So different scoring systems, as long as you adapt one scoring system to know the outcome, that's good. So this trial looked into what are the predictors of EVD placement in patients with an ICH. Again, this was a retrospective review of around 500 patients. 40% of the patients had intraventricular hemorrhage, as we have seen from the literature. EVD will require insertion in about 36%, and usually within the first 5 days of admission. Now, in 16 patients, 16%, they also had intraventricular, they inserted TPA within the EVD just to, remove the clearance of the CSF. Now, this group noticed they had dual catheters within about 7% of patients. Now, patients with dual catheters, they had larger amount of IVH volume, so it was around 56%, versus those that when compared to those with single catheters. Now, what were the predictors of EVD placement? If your GCS is poor, you're going to place a catheter. If, as we also mentioned, the Greb score 5, 1 to 12 was the range, so if it is more than 5, they require an EVD. If they had a non-lobar hemorrhage, less than 30 cc's, they require an EVD. What were the outcomes of EVD placement? The EVD, it reduced the mortality, it improved the outcome, as well as in patients with hydrocephalus, also it reduced the mortality, even after you control the GCS as well as the IVH severity. So, it has reduced mortality. So what about if you have blood within the third ventricle? What is the significance for it? So over here, they analyzed patients with intracerebral hemorrhage less than 40 cc's. They took patients, then over here, with severe IVH. Severe IVH was one of the scoring systems, the Grev's score or the Leroux score. And these patients had hydrocephalus. They got intraventicular thrombolysis. And the exclusion criteria were if they were coagulopathy, any form of coagulopathy, that is over here oral anticoagulation, if their INR was elevated, or if it was secondary, as in case of tumors, traumas, AV malformations, or if it was infratentorial in origin, or if they had hydrocephalus from mass effect, and from blockage of the foramen of Monroe, or if they were enrolled late and young age. So what they noticed, again, they noticed a modified Round-Kern scale at 90 days. 0 to 3 was considered as good outcome. So what happens with the third ventricular blood? They included 50 patients. The ICH volume was around 12 cc's. The IVH volume was high, as you see, 30 cc's. So that's pretty large. So usually the third ventricular blood clears up in about 3 to 5 days. If there was larger amount of IVH volume within the third ventricle, they correlated with poor outcome even after controlling for other factors. So the amount of blood within the third ventricle, it can correlate with the outcome. So the outcome in this group was not correlated, did not depend upon age. The total amount of blood in other ventricles, the lateral ventricles, the location of the hemorrhage, if there was pupillary asymmetry, fever, infection, blood pressure, and blood glucose. So the other parameters did not correlate. So the possible mechanism is like if there's large amount of third ventricular volume blood, more amount of brainstem structures are damaged, and then so you'll have a higher mortality. What about the prognostic significance of IVH if it is small volume ICH? Now, small volume ICH was if the volume was less than 30 cc's. So they took deep hypertensive hemorrhages. So out of 330 patients, 33 met the inclusion criteria. Again, they used the Leroux score and they measured the outcome at 30 days with the Glasgow outcome score. And then the patients were divided into 3 groups. The first one was a control where they did not have any IVH. This was the middle score, 1 to 8. The score of 16 was the maximum, right? So this was over here more than 8 to 16. Okay. So then again, like what did they notice? The baseline characteristics of the patients were similar, but the patients with IVH score, larger IVH score, they had a poor GCS, they had bigger temporal horns, they had longer length of hospital stay, they had more general medical as well as neurological complications, and they had poor outcome. So the amount of blood within the ventricles, it does correlate with the outcome. Now, which of your patients with IVH require a shunt down the line? So again, in this trial, around 200 patients, we know from our basic, the same 40%. So this patient, they had 50% of the patients had IVH. EVD was placed in 75%, there are 75 patients, but some of them required it only for ICP monitoring. Nearly 28% of patients required a VP shunt. Now, who are the patients who require a VP shunt? These patients had a longer length of hospital stay, but they had shorter length of ventriculostomy catheter days. Now, which are the predictors? If you have a thalamic, then ICH. These are the patients who will require a VP shunt frequently, as we've already seen. And if their ICPs are more than 25, these are the patients who require an a VP shunt down the line. What is the impact of IVH upon hematoma expansion? So we may think like, hey, blood is going into the third ventricle or the lateral ventricle. So, the expansion of hematoma would be lesser because like it's a low than a resistant system. So does it prevent hematoma expansion? Because our patient had hematoma expansion, right? So like, does decompression help? So like, again, this was a retrospective review. So 70 patients were included. The inclusion criteria, they were included within 6 hours. So they were more than 18 years. They did not have surgery before the second CT. Follow-up CT was done within 48 hours. There was no underlying coagulopathy. Then exclusion criteria, if they were enrolled within the FAST trial or if they were posterior fossa hemorrhage. So now the patients were divided into 2. So we all know that based upon the location, paraventricular, there is thalamic as well as caudate. Okay, so and non-paraventricular, that is if it was lentiform as well as lobar in location, and if they had IVH or no. Okay, 85% of patients within this group had IVH. So what did we they noticed was patients with IVH similar baseline characteristics. Only like we know that if it was thalamic or caudate, you're going to find IVH most frequently. So if patients had IVH, it was most likely paraventricular, which we've already explained in different sizes. But the volume increase with patients with IVH was high, both absolute volume as well as relative volume and the final volume. All the volumes were increased if they had IVH. So IVH does not restrict, hematoma expansion. As well as what happens if your location is periventricular, not periventricular, paraventricular, I need to say. So the volumes, if it was non-paraventricular, it was smaller. This was 8 and this is 23. And so the initial volume was lesser. The increase in volume was also lesser. The final volume was lesser. Okay. So now how do we correlate everything else? So what did they notice was hematoma expansion. This is the hematoma expansion over time. So this is if they did not have an IVH. This is if they have an IVH. This is based upon the location. Hematoma expansion occurred in all the groups. So the location did not correlate with hematoma expansion. So presence of IVH does not limit hematoma expansion. Of course, you'll find it more with the lobar and the lentiform nucleus, but it's there in every patients. Even caudate will expand, even thalamus will expand. So IVH does not restrict hematoma expansion. What if you don't find IVH within the first CT and you find it delayed? So again, this was a prospective review for around 200 patients. So all traumatic and secondary etiologies were excluded. They performed here then a CT scan on admission, 6 hours, 24 hours, 48 hours, or if there was any mental status change. So initial IVH, again 48% correlates with the literature, but delayed IVH was seen in 20%. So that's a big number. So now what was the characteristics of patients with delayed IVH? They had more amount of atrial fibrillations. Patients with delayed IVH, they were most likely to have blood within the lentiform nucleus. Whereas with initial IVH, most likely thalamic and caudate in location. So the interval, usually the difference, interval between the symptom onset and delayed IVH was around 8 to 9 hours. Typically, this was the time when they noticed on the second CT. So most of the delayed IVH were detected on the second CT scan, that is after 6 hours when they did it. Maximum duration was around 72 hours. So in all these patients, you need to get a second imaging, So you just have to get it fast because you're going to miss in 20% of the time. And delayed IVH also did correlate with hematoma expansion. 43% of these patients required a surgical intervention like a cranie or an EVD. So that's a big chunk. Also, it correlated with death as well as disability. So serial imaging is very important in patients with ICH. What about we have used recombinant factor 7 on IVH. Did it limit the growth of IVH or no? Again, we all know the FAST trial. It inhibited the hematoma expansion as such, but it did not then translate to the outcome. So what correlationship it had with IVH? They had around 399 patients. 374 were randomized to a factor 7 versus placebo within 3 hours of the symptom onset, so very rapid. So baseline IVH again seen in about 40%. So at 24 hours seen in 45%. Now the IVH growth was much less in patients who received factor 7A. So it does limit, the growth of IVH. The risk factors of IVH growth were if your MAPs are higher, blood pressure is higher. If they had larger initial blood volumes, it was higher. If you had IVH at baseline, those are the patients who will expand. If you had a shorter symptom or the time from symptom onset to a CT, like if you come in early, that means you're going to expand more, because usually expansion you see it within the first 3 hours. After the next 24 hours, the expansion is much more lesser. So if you get it earlier, they're going to expand more. Whereas if you get it later, you may compare one CT to the second CT, and you may say, oh, it's not expanded. So it all depends upon how early you're getting your CT scan. If they did not get a drug, then those people expanded. Okay. So this is then a very busy slide. So this is the poor modified ankle scope, then 4, 5, 6, and this is 0 to 3. So the top slide is if there was IVH, if it was present. So this is if they got placebo versus the factor 7. As you see, if the IVH was present, outcomes were better. And if there was no IVH also, that is for the ICH, the outcomes were better. And then the IVH growth. So if there was IVH, if there was presence of IVH, the IVH growth was much more lesser, and you see the poor outcomes were much more lesser when compared to the placebo group. Okay. If there was no IVH growth, also the outcomes were much more greater. You see, the top columns are those with the placebo, so the outcomes were worse with the placebo when compared to those with the factor 7A. So what were the predictors of death and disability in this group? If they were elderly, if they had a lower Glasgow Coma scale, if they had a larger ICH volume, if there was an IVH growth of more than 2 cc's, if there was IVH at baseline or at 24 hours, or if they did not get the treatment effect. So only 7% of patients who had an IVH growth had a good outcome. So which means any amount of IVH growth is not translating into good outcome. So that is 93% of the patients who had an IVH growth did not have a good outcome. So IVH at any time. If there was any growth, worse outcome, increased morbidity, increased mortality. What we also know is like, hey, blood pressure, it's a risk factor for IVH growth. So you need to control the blood pressure aggressively. So now this was a small data, when comparing, conservative versus EVD with thrombolysis. So like, the case fatality rate, if you don't do anything, if you have an IVH conservative treatment, 78% case fatality. If you have an EVD, it is reduced to 58. Whereas if you give intraventricular TPA, it is reduced to 6%. Okay, so this is for the fatality. Again, the poor outcome, it was high if you don't do anything. If you put an EVD, it's lower. But if you put TPA, again, the poor outcome is much more lesser. So this was the initial study which shows, intraventricular thrombolysis, you use it. Okay.
Are those primary IVH or secondary?
These are all secondary, most likely secondary. I mean, like primary, you see it only in 3%, right? It's very rare. Primary is very rare. Like, these were all secondary, mainly hypertensive. Most of the things. They excluded all the patients with tumors, heavy malformations. So those causes were excluded, but low bar and amyloid were the ones which were included. So again, this is a meta-analysis. Like even the meta-analysis, like it is very difficult to get in patients. Like they had around 300 patients, out of which 150 patients were enrolled within the thrombolysis group. So the mortality was definitely much more lower with the EVD alone, and with EVD and TPA, it was even much more lower. So that's why instilling TPA in these patients makes sense. Because and they also know compared urokinase is not here, but in Europe they use it. So urokinase had a better effect when compared to TPA. So this data had come out. So this is the inclusion-exclusion criteria which have been used in the trials. So like indications if the indications if it was secondary to supratentorial ICH, or if it was aneurysm. Once the aneurysm is fixed. If they had hydrocephalus, you would use it. If there was third or fourth ventricular blood, you would use it. Or if your IVH score was higher. Contraindication, if there's too large, of IVH volume, it makes no sense, because you're going to damage more tissue. So if your volume is more, if they've been on antiplatelet therapy or anticoagulation. We are having one patient, right, with Hep C who has coagulopathy, got TP and then worse. So if the coagulopathy is a contraindication of intraventricular TPA. If it was infratentorial, they excluded them. If there was hydrocephalus from mass effect, these patients are excluded. Now, when will you instill, bilateral EVDs? There are no clear-cut guidelines. Okay? So usually you put the fossa or the catheter in the lateral ventricle with this least involved. The main thing is you just want to lower your ICPs and you want to relieve the obstruction. Okay? Is that enough? Is that enough to reduce the blood from the other ventricle? No, it's not enough. Because the foramen of Monroe gets obstructed, as well as even the catheter gets obstructed. So that's why they put a second EVD. The initial data knew if the hemorrhage volume was lesser than 40 and if the IVH volume was 30 to 35, there was no benefit. So this was the prelim data. Okay, so this the Hopkins group looked into when did they put in the second EVD. So if either the ventricles were completely trapped, that means the foramen of Monroe is completely obstructed, you're going to put a second EVD. If they had bilateral castor, that is over here, bilaterally, the lateral ventricles are completely filled up with blood, you're going to put it. If your EVD gets obstructed frequently because of mass effect, you're going to put it. And if your mass effect from hydrocephalus is really bad, then you're going to have a second EVD. Or if your IVH volume was more than 70. In a previous trial, we knew that it did not benefit between 30 to 35. So if it was more than 40, then it really helped a whole lot. So that's why, IVH score, IVH volumes make sense. You need a second EVD. Now this was very small study, so the outcome data was not translated, but definitely it cleared the CSF faster when compared to that of a single EVD. Now what impact does blood glucose? We all know that blood glucose in intracerebral hemorrhage is very bad, but what about its effect on IVH? So this is if your blood glucose level is high. Again, this is if your IVH score. So they define hyperglycemia if it was more than 180. If you had significant hyperglycemia, the IVH score is going to be high, as well as the mortality is going to be high, the disability is going to be high. It also it correlated with the significance of IVH extension. So that's why sugar control is also very important in patients with you have IVH. Now, which of your patients? What about imaging? So what is the value of imaging in patients with ICH? So this was, this group looked into if you did MRI within 7 days or if you did beyond 14 days. And you excluded usually the indications where either it was just a follow-up or they had cognitive decline, stroke, seizure, etc. There were 66 patients who had MRI in both the groups. Okay? You find the DWS positive in about 16%. So it's not a small number. And even 7 Tesla MRIs, the sensitivity is even more. So it's not uncommon that you find an ischemic stroke sitting along with a hemorrhage. Okay? It just indicates that it's the same small vessel disease which is there. One area is blood, one area is not blood. So most of the lesions, where these were located were lobar, and they were not uniformly located, as you see. So these are mainly lobar, right? So the frequency between the two periods, the frequency and the distributions were similar in both the periods. So this was the red spots are the non-acute and the yellow spots are the acute. So this was lobar. Okay? And what they noticed was if it was a lobar hemorrhage, it was mostly in the frontal lobe. Whereas if it was a deep ICH, basal ganglia ICH, the location was mainly parietal. That was the pattern. So the frequency and the distribution were similar in the acute and the non-acute phase. Okay? And even in the patients who had MRI in both the periods also, it was similar. So there was no particular pattern to it. You will find DWI lesions. And in the acute group, they were mainly older. They had more likely to have diabetes, and they had fever. Okay? So DWI lesions are very common in patients with hemorrhagic stroke. So what is the utility of getting an early MRI? So this was again retrospective review. They did then a CT as well as MRI. Usually the MRI was done within the same admission. They excluded patients if you had a known vascular malformations. And usually the final diagnosis was commonly hypertension or amyloid angiopathy 50%. But then they did who was then a reading and making a final correlationship. So for a vascular neurologist, addition of an MRI, it changed the diagnosis in about 14%. The confidence with which a person can make a diagnosis in 23% and the management in 20%. So I think getting an MRI in these patients makes sense to know because your management can change in 20% of the time. So the yield was highest if you had an ischemic stroke with hemorrhagic transformation, amyloid angiopathy, AV malformations, and neoplasms. Our patient also had cancer, right? So lucky she did not have any underlying lesion. So the MRI yield did not differ with age, hypertension, the location of the hematoma, as well as the presence of IVH. What will you do if what is the significance of getting a CTA in patients with intracerebral hemorrhage? About 33% of them have a spot sign. Now CTA, this is like the non-contrast. This is the CTA, that is the initial image where you see the spot over here. And then this is the post-contrast, you can see the hyperdensity over here. And this is 24 hours later. See, the small amount of blood has become bigger. So now different. So this is why the significance of the spot sign is very important. Seen in about a third. It's a predictor of hematoma expansion. Even the volume change is also bigger. Okay. These patients definitely, once you have more hemorrhage, you have longer length of hospital stay, poor outcome. Okay. So what about the spot sign score? So this is a score, very a simplistic score they have been using in research. Number of spots, which is 1 to 2 or more than a 3. What is the size of each spot also they measured, as well as even the density of each spot. Because if you get a CTA a little bit too early, if you take those images, you may miss a few spots. If you wait for 90 seconds, you may get more spots. So that's why they wanted to correlate. So if the more the spots score, the risk of hematoma expansion was higher. So so if your score is higher, hematoma expansion is higher. Okay. So if you get a spot sign score, so it was independent of the time. So that's why even if you get an early CTA, without waiting for it, then it was not correlating with you're missing the things. Okay. So spot sign score, people who had the score and if they had surgery, they bled a lot during the intraoperative period as well as post-op. So because when they bleed a whole lot, you're going to have large amount of residual ICH even after you removing the blood. So that's why it's very important. Now what about the spots other than assigned score and survival? See, as the number of spots are increasing, the survival is also reduced. So these are the patients who expired, these are the patients who survive. So simplistic score can tell you how the outcome is going to be. Okay. What about a catheter angiogram? Is your catheter angiogram going to be helpful if you have an IVH or no? We all know that, from their background, the presence of an IVH is if they are young, if you're a woman, if you do not have any hypertension, if you have intact coagulation system and lobar ICH, the yield of catheter angiogram is going to be higher. So now this group looked into patients, divided them whether they had IVH or no. They excluded all the patients with underlying catheters like AVMs, neoplasm, surgically evacuated, or they had a subarachnoid. So, with IVH or without IVH, around 90% of the patients had a vascular lesion. So the baseline characteristics was similar, and then there was no difference, patients between the patients who had an IVH and no IVH. So there was no difference at all. In fact, then patients with IVH were most likely to be hypertensive and coagulopathic. And those without IVH, they had a high probability CT. Now, what they defined high probability CTs if they had enlarged veins, if they had some calcification, suspicious looking areas, Low probability means that is the deep ones, you're not going to find a lesion, most likely hypertensive. So, yield of catheter angiogram with IVH and without IVH, it was the same, So, it does not mean that presence of IVH will increase the yield. So, what about the yield of catheter angiogram in the primary IVH? As we said, primary IVH, very rare entity. And then this group, out of 550 patients, they had only 15 patients with primary IVH. We know it's a very rare entity. These were the deficits that they presented with. EVD was placed in 70%. We also said that primary IVH had a better prognosis when compared to secondary IVH, independent in 53% of the time. But and 60% of the patients underwent angiogram. 44 of them had a positive lesion. So that means if you are having a primary IVH, they need to have an angiogram because your yield is going to be very high. So they need to, have it because AVMs can be fixed. So which of your patients will have early neurological deterioration? Our patients deteriorated, right? Within the next 6 hours. So this was early neurological deterioration. This was a very old paper. So they use a Canadian stroke scale, and if it was more than 1 within 48 hours, this was called early neurological deterioration. It occurred in about 20 patients, So patients with elevated body temperature, elevated white count, elevated fibrinogen levels, at admission, it correlated with outcome. And again, at 48 hours, if they had an ICH growth, IVH, or if your blood pressure was elevated. In our patient, the blood pressure was normal, the temperature was normal, she had a normal white cell count, she had a normal fibrinogen level. Despite that, she declined. So this is a large meta-analysis which compared again, what are the predictors of early deterioration. So now early neurological deterioration was if they had death or worsening within 7 days from symptom onset. 2,000 patients were analyzed. So if your volume was higher, or if you had IVH, or if you had hyperglycemia, elevated fibrinogen level, and D-dimers, these are your patients who are going to decline over the next few days. But interestingly, they found that history of hypertension, the blood pressure on admission, or the ICH Hematoma Expansion was not. Interestingly, in a large meta-analysis, this was cancelled. Now, which of your patients can have a late neurological deterioration? So now the late neurological deterioration was, the GCS was more than, decrease in GCS by more than 2, or if they died within, then from 48 hours to 1 week. So late neurological deterioration seen in about 29%. Now, which of your patients can have late neurological deterioration if you had a larger volume? Again, IVH. IVH has a big picture. If you had hyperglycemia, if you had midline shift on admission. So these are the patients who can deteriorate on the line. And then, so if you had late neurological deterioration, you are going to have poor outcome. Okay. What is the impact of fever? We all then aggressively manage fever. This was prospective study of about 300 patients. What they noticed is they compare the temperature about 37.4 and then the amount of duration of time. They noticed that this is patients with hematoma growth and this is non-hematoma growth. This is the modified Rankin scale. If it was 4, 5, and 6, this was then 2 and 3. And then so like, at 72 hours, if there was cumulative fever, they had more amount of hematoma growth and poor outcome. So that's why, it does have an additive effect. And poor outcome was again, like, notice at 168 hours, if you have fever, you're going to have poor outcome at 90 days. So, it does have a cumulative effect. Okay. So what about if you aggressively control the blood pressure? So, this group, like, they divided into two. One is the routine fever management. Two is like, do everything to control the blood pressure to 37 degrees. There was no difference in outcome. Okay. They had 40 patients in each group. In fact, patients who had aggressively managed with fever, more amount of sedation days, mechanical ventilator days, ICU days, frequently underwent effect. So, too aggressive management did not improve outcome. Now, which of your patients are then here? What are your characteristics of strokes, intracerebral hemorrhage in the young? Now, young age, they put this as the division between less than 50. So again, it was a prospective study of around 98 patients. They had about 50 patients in both the groups. Okay, and like the most common etiology in less than 40 was AV malformations. Between 40 to 50, again, it was hypertension. The case fatality rate in the young, you see, it's much more lesser, it's about 20%. Okay? People who died where they had a higher NIS score, lower GCS, most of the deaths occurred within the 10 days. Okay? Poor functional outcome was seen in 50%. And again, poor functional outcome was if they had a higher NIS score, if they had a large volume ICH, or ICH from hypertension. These were the predictors of poor outcome. Long-term mortality is low if they are young, it's about 12%. Now, recurrent bleed, how, this was a follow-up study of 11 years, so that's a huge thing. Recurrent hemorrhage in young individuals you see in about 8%, at 10 years you see in 12%. Most of the recurrence were from vascular malformations, so that's why that needs to be very much. So what is the difference between the young and the old? Now the young and the old, they put the cutoff of around 50 and then 50. So the most common prevalent fact in the young was unknown, so we do not know. And then like hypertension was the second most, structural lesions were the most common. Okay. Now young patients most likely when they compare with old, they most likely had structural lesion, less likely hypertensive, less likely we know that stroke risk factors. Now these patients, they had lesser severity. Their NIS score was much more lesser, for the same amount of blood. So their symptoms were milder, when compared to an older person. Okay? And in fact, like, hematoma volume was not a predictor of mortality. See, like our patient is walking and ambulatory, she was completely bleeding. So again, a young person does move much better, for the same volume of hemorrhage. Okay. Now, how do you what are the predictors of hematoma volume in both then a deep and then a superficial? Okay, so like they compared. The ICH volume, definitely it's more large in the lobar. We know like in the lobar there's more space, so there's more volume. So what are the predictors of the hematoma volume expansion in deep and superficial? For deep was anticoagulation if they had coronary artery disease, male gender, as well as increasing age. Whereas for the lobar, it was anticoagulation and antiplatelet. So only some of the risk factors are shared between both the two. Now, comparing apart, this is for hematoma expansion. What about a CTA spot sign? Again, the same group, looked into what are the predictors of spot sign. So in a deep one, again, was then if you're using anticoagulation, if your volume was higher, or if you're getting an earlier CT. For lobar hemorrhage, again, it was warfarin, or if they had larger ICH volume. So the spot sign scores, some of the parameters were common to both. So it indicates like, hemorrhage has certain commonality between both the locations. Okay. Which of your patients can have hematoma expansion? Different formulas have been used. You can see it in 70% of our other patients. What are the predictors of hematoma expansion? We know elevated blood pressure, anticoagulations, antiplatelets. If they have kidney disease, liver disease, blood glucose, fever, leukocytosis, genetic mutations. Okay. If you had IVH, they can have hematoma expansion. Larger volume ICH. If they had irregular shape, our patient had an irregular shape hematoma and heterogeneous. So that was the only risk factor in her, to cause a repeated hemorrhage. So then this paper evaluated the speed of the hematoma growth. So that is over time from symptom onset to getting the CT. So that's how they divided. Okay, this one's CAT scan symptom started at this time, and the CAT scan is done at this time. So they divide the hematoma growth into 3 different things: lesser than 5 cc's an hour, between 5 to 10, and more than 10. So if there was more amount of hemorrhage, definitely poor outcome. No, it's a commonality. Okay, so this was the INTERACT trial. So they aggressively managed the blood pressure, took less than 140, and routine guideline management of 180. Okay, blood pressure did not influence any of the three groups. Okay, so management of blood pressure did not influence the hematoma growth at all. So that means, like, the interactive, like, it did not influence the hematoma growth, but the final cognition was better, right, in patients who are, controlled less than 140. So, so blood pressure may have different mechanisms besides hematoma growth. That's how it's maybe altering its way of cognition. Okay. Now, which of your patients can go into brain death? So, like, it's a simplistic formula. Okay. So, like, out of 79 comatose patients, around 49 went into brain death. 39 patients of them had withdrawal of care, and only 12 patients, 12%, were discharged alive. Okay. Simplistic models they use. The first model is like, if they had at least lack of 3 brainstem reflexes, and if they had the swirl sign on the CT. So this is the swirl sign. You find, surrounding, there's a hypodensity and surrounding hyperdensity. That means that area is bleeding model. Okay. So this was model 1, good prediction. Model 2 was if they lost, 1 or 2 corneal reflexes plus the swirl sign. Okay. So this was high probability if they lost 1 or 2 corneal reflexes, and if they had the swirl signs. Okay. So that means over here, all of them, these are this is from withdrawal of care, and this is brain death. Okay. So this is like, low means if they did not have the swirl sign, corneal reflexes were present. So this was low probability for brain death, and intermediate was in between the two. So corneal reflex, good important thing, to evaluate these patients. Okay. And quality of life for ICH, despite like, aggressive management, so around from the FAST trial, 600 patients were enrolled. 95% of them completed the European quality of life. Only 13% of them had a score of perfect quality of life. So very poor disease, to have. 2% of them had described it as worse than death. What were the predictors of poor quality of life? If they had advanced age, if they had a higher baseline NIH score, they had elevated blood pressure, if the volumes of hemorrhage were higher, if it was deep, because they have persistent deficits, or if they had like a decline within the first 72 hours. So these patients would have poor quality of life. Okay. Now this is a long-term meta-analysis. So out of in this meta-analysis, like 1 year survival was about 50%, 5 year survival only about 30%. Okay. So the predictors of death would be if again they are elderly, lower GCS, they had large volume IVH. Again the similar things. Recurrent hemorrhage in the large meta-analysis were around 1 to 8%, so 8% chance, of recurrent bleed. More so if it is a low bar hemorrhage, when compared to the others. And with all that, I complete my presentation.
When you said you calculated IVH volume, is there a formula like I said volume or?
So those 3 formulas were there, right? No, the IVH, those are volumetric analysis.
Based on CT here.
Based on CT, yeah, software, and then like manually doing it.
Yeah.
They all manually did it. I mean, you use a formula, but then like those were different studies, right? That's why they use different formulas and
different scores for
different scores, different. Yeah, the Grave score more than 5, Leroux score more than 8 to 16. So those are the ones. So that's why knowing one thing is good,
What is the pathological substrate of the spot sign?
It just indicates that like the arteries are tearing and it's a leaky vessel. That's it.
So it's just blood?
It's just blood. It's leaky vessel. The blood vessel has ruptured at that site. That's what. It's actively bleeding.
Coming out of the vessel.
It's leaking. It's broken. It's torn there.
It's in the post-contrast study. So you see a pre and post-contrast CT scan and post-contrast you see the spot lighting up. That means that contrast accumulating there. Here there's an aneurysm. There's a microbleed that is ongoing.
So this
contrast that gets out of the vessel and remains there.
So this is when you give the contrast, okay, when you get the CT, that is the source image, okay, and then this is after, this is after. So you have to correlate both, so those are the things. That's why it makes sense, these are your patients, 30% of them are going to decline.
And is the swirl sign the same thing for
Yeah,
lungs?
swirl sign is also actually bleeding, right? Correct. Swirl sign was initially described in epidurals and subdurals, so it was in the 1980s. Swirl sign is no contrast. You don't need a contrast. You just need a non-contrast CT. Just get a non-contrast CT. You see, hyperdense. Our patients, initially, if you see, our patients also had like, very. It was very heterogeneous in hers. You see? She had some areas, which are patchy, and that's why she expanded, right?
So with a lobar bleed like this one, this would be more likely to be an angiophilic, congophilic angiopathy, amyloid angiopathy. Or
I think hypertension was her triggering factor, but because of FMD, she had I think leaky vessels, so that was the thing.
So FMD usually is considered mainly to be extracranial.
Yeah.
So you're saying that FMD caused her
No, it did not cause this,
very
but the whole thing is she must have had dysplasia, right? How do we know at microvascular level, right? There's no way to prove it, right? And there are no studies. I looked up into everything.
Yeah, sure.
It's mainly extracranial. I agree, And then initial CT, angio was suspicious. There's some vasculitis, but later looking at it, it was not. So I think, it's at microvascular level, it can cause, thing. Because you can have subarachnoid hemorrhage, right? What if she would have had a small micro, aneurysm, which must have ruptured? We don't know, right? She had a 4 millimeters incidental other aneurysm also, right? Correct? So we don't know, because she continued to expand at 8 days. So she continued to, despite everything, she continued to become worse and worse. So that means there's something underlying besides hypertension, right? How frequently in hypertension will you see even after 4 days and when you expand? Unlikely, right? That means you're missing something else. Where hers was renovascular hypertension, non-compliant, because lisinopril 20, this thing. So, I think, so there's underlying thing.
On the ones with ventricular drains, you said thrombolysis improves it. Are we doing that here?
Yeah, IVT here we do it. Yes.
How do we do it? Do we put it in through the tube? And
Yeah,
what's the dose?
they remove and then they flush it, right? 1 milligram. Yeah. You have a maximum limit of around 20 milligrams, so you use 1 milligram TID maximum. You give a maximum dose of 20. That is in these trials, okay? Yeah, but you have to be careful, right? Sterile meningitis and everything else. Your edema can get worse. You have to be careful who's touching the drain.
But does the finding that this spontaneous ICH correlate also with hemorrhagic infarction, hemorrhagic transformation? It's
No, they are different.